Everyone. Thank you for joining, and thank you for those that are slowly joining. Today is the third session in our age-friendly geriatrics teleecho series. We have one more session after this next month, and then our series will be done. I hope you've enjoyed it so far. So today's agenda, we're just going to go through our regular welcome, introductions, and announcements. And our didactic topic is managing depression, anxiety, and insomnia in older adults, followed by our case presentation and then closing and reminders. Just a quick reminder, please be sure to mute yourself when you're not speaking to prevent background noise. Introduce yourself if you have any questions so we know who you are, and just always maintain confidentiality when speaking about patients, and then respect others and their opinions. This series is accredited for a CME, and you will receive a CME form via email after this to fill out if you do want CME credits, and your certificate should come to you via email. So each session is one CME credit. This project is grant funded by the Health Resources and Services Administration of the U.S. Department of Health and Human Services. And this information or content and conclusions are those of the authors and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. So we'll move on into our introductions. If you are joining us today, please go ahead and in the chat, put your name, role, and site and location if you can. We'd love to see where you're joining from. And we'll have our hub team go ahead and introduce themselves. I'll get started. My name is Mika Seville, and I'm joining from Orange, California. And I'm the project manager for our geriatric workforce enhancement program. And Dr. Gurvich.
Hi, I'm Tatiana Gurvich. I'm a professor of clinical pharmacy at USC School of Pharmacy, and my practice site is at UCI Medical Center, the Department of Geriatrics.
Thank you, Dr. Gurvich. Dr. Campbell.
Hi, my name is Sarah Campbell, and I am a family nurse practitioner at the School of Nursing. I'm an assistant clinical professor and also practice on site at the Student Health Center here at UCI.
Thank you, Dr. Campbell. And Dr. Stagel.
Hey, everybody. Welcome. I'm Sonia Stagel. I'm a clinical professor in internal medicine and geriatrics, and my practice site is in Orange at the UCI Senior Health Center.
Thank you. And Dr. Gibbs.
Hi, Lisa Gibbs here. I'm a geriatrician and I lead the geriatrics division at UCI. I'm also a geriatrician with a practice at the Senior Health Center.
Thank you so much. And thank you to those that have introduced themselves in the chat. Welcome to this session and thank you for joining us today. We will go ahead and move on into our didactic topic today, which is managing depression, anxiety, and insomnia in older adults, presented by Dr. Gurvich today. So Dr. Gurvich, you can take it away.
Okay, thank you. So we're actually going to focus on depression and insomnia management, touch a little bit on anxiety, but not a whole lot. If you have questions about anxiety, I'm happy to answer them afterwards or by email. So let's start with insomnia. Next slide. We're just going to talk about the prevalence of insomnia, how to manage it primarily with medications and without, and review which medications are safe and which medications should be avoided, and talk a little bit about sleep hygiene and sleep stages and things like that in an older patient. Next slide. So it's a very common problem. 57% of people over the age of 65 present with some kind of insomnia. So we see it very frequently in our clinic. It's a very expensive problem, and there's serious consequences that result from it. Daytime dysfunction, decreased quality of life, psychiatric disorders like anxiety, depression, and obviously increased mortality. So it's something that we have to deal with and that we deal with often, and there's not necessarily a good solution to it. Next slide. So some of the age-related changes that happen with sleep, there's generally a decline in sleep quality and duration. So generally speaking, older adults don't sleep as long or as well as younger adults. And so that's something they have to get used to, and that's something we have to kind of explain to them as we're managing this problem. There's a decrease in sleep efficiency, depth, intensity, and continuity. So there's a lot of middle of the night awakenings, and that they just don't have the deep sleep that their younger counterparts have. There's weaker circadian regulation, so oftentimes patients will get night and day mixed up. They experience more frequent awakenings, early morning awakenings, and increase in sleep latency. Next slide. So just to review normal stages of sleep that happen in everybody. So the stage 1 typically takes 5 to 30 minutes where you're basically relaxed, your eyes are closing, and you're sort of thinking about going to sleep. Then you get into stage 2, which is where you disconnect from the outside world. You can't really hear a lot of noise, but very noisy things like a door slamming will wake you up. So it's a sleep that you're easily awakened from. Then stage 3 and 4 are deep sleep stages. Those are sleep stages with a lot of delta waves, and this is really the restorative sleep that we all need to be able to function well. And then there's REM sleep, which is the dream part of sleep. So we kind of go in and out of those stages throughout the night. Next slide. So this is a representation of what happens in a younger adult versus an older one. As you can see, the graph on the bottom shows a lot of fragmentation. People jump in and out of different sleep patterns during the night, and overall, an older adult doesn't spend as much time in deep restorative sleep. So stage 1 typically is extended. It takes them a little bit longer to fall asleep. They spend most of their time in stage 2. Stage 3 and 4 are shorter, and actually REM sleep is shorter in older patients as compared to younger ones. So the quality of sleep they get is different, and it's a natural age-related change. Next slide. So how do the hypnotics that we traditionally use affect the sleep cycle? Well, they shorten stage 1, so it does. These medications do allow patients to fall asleep faster. What happens is they spend more time in stage 2 sleep. So they spend the majority of the night in the kind of sleep that's not deep restorative sleep. And most of these medications will actually shorten stage 3 and 4, or deep sleep, so that they spend less time in it. And they also shorten REM, so there's a little bit less dreaming going on when they're taking these medications. Next slide. So what the research has really shown is that non-drug therapy should be the first line option for treatment of insomnia, and it's actually more effective. They've done multiple trials, and there's a meta-analysis listed on this slide of 23 randomized trials showing that cognitive behavioral therapy, relaxation, non-pharmacologic approaches like sleep hygiene education really improve sleep significantly better than medications. This meta-analysis didn't compare individual forms of non-pharmacologic therapies, but in total, generally speaking, these therapies are more effective than medications that we prescribe. Next slide. So when I get an insomnia patient in my clinic, one of the things I do is a little sleep hygiene education. Anybody can do it. A nurse can do it. A physician can do it if you have time. Occupational therapists, some are trained in sleep hygiene, so they can be effective in helping patients do some of this. But basically, what you're doing is you're getting a 24-hour recall from a patient of what happens to them during the day and at night, so you can figure out what things you can change behaviorally to improve sleep. So they have to have a regular schedule. They have to go to bed only when they're sleepy, not when they're being told to. You have to cover the alarm clock so you don't, when you toss and turn, you don't look at the time every 15 minutes because that provokes anxiety. You should get regular exercise during the day, preferably in the early part of the day and not in the evening or nighttime. You want to avoid large meals at night because that disrupt sleep as well. Limit alcohol and caffeine. If you want to have caffeine, only early in the morning. You want to make sure the bedroom is comfortable. The lighting, it doesn't penetrate through the curtains at night, and there aren't any extra flickering lights. and you want to do something very relaxing before you go to bed, maybe not watch the news or fight, boxing matches or whatever, and just kind of relax and get prepared for sleep. So going through this daily activity log is really helpful. Every time I talk to a patient, I'll always find one or two things they could be doing differently, and sometimes that's enough to send them in the right direction of managing their insomnia without medications. Next slide. So this is just to give you an idea of how much caffeine is out there in products. So a cup of coffee, an average cup of coffee is about 300 or 266 milligrams. Starbucks is usually more potent, up to 320. Brewed tea can potentially have significant amount of caffeine in it, especially if you leave the tea bag in. Chai tea latte, which is mostly sugar and other junk, still has 100 milligrams of caffeine. Some sodas out there like Snapple, Mountain Dew, Diet Coke, they all have caffeine, so that's something to keep in mind, kind of get a cumulative amount during the day so that you can figure out if it's too much for the patient. Even ice cream has some caffeine depending on what kind it is, and hot cocoa. So go over the dietary stuff that patients do. And then because I'm a pharmacist, I'm always going to look at medications that are already on the list to see if any of them contribute to insomnia. So obviously diuretics can really be disruptive to sleep, so make sure that if they do need a diuretic, it's taken in the morning. Sometimes doses are split, and so patients end up taking them multiple times a day, and that can lead to frequent awakenings just to go pee. Dopamine agonists can contribute to poor sleep. Some antidepressants, especially activating ones, we'll go through that in a few slides, can also contribute. Thyroid replacement, if somebody's hyperthyroid or hypo, that can produce poor quality sleep. Hormone replacement therapy can sometimes contribute to insomnia, and obviously stimulants and herbal supplements. If your patients are taking a lot of supplements, look at the ingredients in each bottle to make sure there isn't stuff like green tea, caffeine, guarana, ephedra, anything, bitter orange, anything that can be stimulating. Some antipsychotics can produce insomnia. Dementia medications like donepezil, cholinesterase inhibitors can do it as well. Steroids either put you to sleep or keep you awake, so it really depends on the patient. Decongestants that are available over the counter are some pathomimetics, things like phenylephrine and pseudoephedrine, can certainly cause insomnia in an older adult. Beta agonists, especially if they're using, nebulizer treatments a lot at night, that can activate them a little bit. So be careful with that, and obviously appetite suppressants and ADHD meds. Next slide. So because sleep hygiene takes a while to go through and kind of implement some of the techniques, and primary doctor's offices visits are 10 to 15 minutes, there's really not enough time to do all that. So oftentimes what we end up doing is jumping to the medications before we do this non-pharmacologic stuff. And almost every sleep medicine that's available at our disposal is a problem in older patients. Over-the-counter medicines like antihistamines are all on the Beers criteria that promote sleep, and they can cause confusion, dizziness, contribute to falling. All benzos and the Z drugs are also on the Beers criteria for cognitive dysfunction, increased fall risk, and things like that. A lot of the sedating antidepressants like tricyclics we also want to avoid because they're anticholinergic and can produce the same kinds of issues as over-the-counter antihistamines. And some of the other things we sometimes use off-label, like gabapentin, quetiapine, and trazodone, can also have next-day sedation if we're not careful with dosing, and orthostatic changes and dizziness. Next slide. So there's a number of articles out there that point to the fact that sedative hypnotics are really harmful in this patient population. There's a very nice, now old, meta-analysis of 24 randomized controlled trials looking at older adults and who are using these hypnotics, and it shows that the number to cause harm is lower than the number needed to treat. So you're more likely to have a side effect or an adverse reaction from giving these medications than you are in improving their sleep and having a therapeutic outcome. Most of the side effects observed are drowsiness, fatigue, headache, nightmares, nausea, loss of balance, dizziness, falling, motor vehicle accidents the next day when they don't remember how that happened. Falling obviously leads to broken bones, and then drowsiness in the morning. Next slide. So when you look at the efficacy of benzos and benzodiazepine-like drugs, what these studies show is that the number of awakenings are decreased by less than one after you use them. So why would you use something that's barely effective that can potentially contribute to a lot of adverse outcomes in that patient's life? The increase in sleep time is less than a half an hour, so it's just not worth using them for this tiny benefit. Next slide. They're also, the use of benzos is very costly. It increases ER visits, it increases healthcare expenditures. There are more hospitalizations resulting from, say, a fall after using a sedative hypnotic. And so the cost of using these medications is really exorbitant. Next slide. So what's wrong with the non-benzodiazepines, that's sort of what we call the Z drugs? When they first hit the market, and I think there's a slide after this one that kind of looks at the kinetics, at first they looked very attractive because short half-life, quick onset of effect, shouldn't be any hangover kind of a picture. But since they began to be used frequently, there's been a huge increase in emergency room visits from Ambien alone. There's a huge risk of hip fractures in nursing home patients from these benzodiazepine-like drugs. And there are lots of really strange behaviors. People have these amnestic reactions from these medications. They wake up in the middle of the night, start making dinner, and then have no recollection of doing it. Or they'll call 5 or 6 family members at various times during the night and again have no recollection of doing it. So there's that huge amnestic component that's seen in this patient population that can be quite dangerous. Next slide. So if you look at the kinetics of these medications, these are the 3 that are available on the market in the United States. They look good on paper. Onset of effect is 30 minutes, so relatively quick. Half-life is anywhere from 1 to 6 hours, so relatively short half-life. So there shouldn't be any hangover effect, but there is. With Sonata, sometimes it's not effective enough, so you end up having to take more than 1 pill throughout the night, and then you get hangover effect. But even with something like Ambien, you do get hangover effect in the morning. What's come out over the last several years are a bunch of different formulations of the same drug, Ambien. Some of it is in a spray, some of it in a sublingual tablet. Some of it has weird disintegrating mechanisms where a little bit is dissolved right away, and then the rest of it is over the next 8 hours. But all of it really creates a problem in the morning because patients are groggy, sometimes disoriented when they take it on a daily basis. And at the end of the day, they really don't get good quality of sleep with these drugs. Next slide. So what herbal supplements are available? The most commonly used thing is something called melatonin. I'm sure we all know about it. The trick with the melatonin is dose. If somebody does have their night and day mixed up and they take very long naps during the day and are awake at night, melatonin can be helpful. You just have to give the patient the right dose. So very frail, thin patients could benefit from as little as 1 milligram. 1 to 3 milligram would be considered low dose, but then you should really work with it and kind of go up. So from 3 milligrams, you might go to 6, and then maybe all the way to 10. The maximum dose is somewhere in the 15 milligram category. Anything over 15 really isn't helpful, and it can actually cause a lot of CNS problems, vivid dreams, things like that. So you don't want to go too high with it. Chamomile can be really sedating, well, not sedating, kind of relaxing. So it relaxes you enough in the evening so that you are able to fall asleep naturally. That can be used. Valerian root is very popular in certain patient populations, like Eastern Europe, for example. Be careful with it. It's a benzodiazepine-related drug, so some older patients will get quite confused on valerian root, and you certainly don't want to use it when you're also using other benzos like Ativan or Xanax. So I don't like valerian root because it's just potentially dangerous in this patient population. Next slide. There's also something called Rosarum or Ramelteon. That's a pharmaceutical grade melatonin agonist. So it works just like melatonin on the same receptors, but it's an actual drug. The milligram is 8 milligram. It's a single milligram, 8 milligram tab. It works, you know, if you get some benefit from melatonin, but not all the way, this may be worth trying. Some insurances are now covering it as opposed to a few years ago when they didn't. So that might be an option for someone who gets some benefit from melatonin, but not a perfect result. Next slide. We use trazodone a lot. Trazodone obviously is an old antidepressant, but at low doses, it can be quite effective in older patients. The trick is to start with a low dose of 25 milligrams, no more than 25 in a geriatric patient, and kind of work your way up gradually up the dosing ladder all the way up to as much as 150. So it may take a while to get to that point, and it's kind of hard to predict at what dose will trazodone be effective for what patient. So some patients do very well on lower end doses, 25 to 50. Some patients need closer to 100, and for some we go above that. So as long as you're seeing partial benefit as you go up the dosing ladder, you can go ahead and titrate up. Next slide. Mirtazapine is an antidepressant that's a very sedating one, and at lower doses, it's actually also helpful with sleep. So a typical sleep dose for mirtazapine would be 7.5 to 15. In your tiny, frail patients, sometimes we start even with half of a 7.5 milligram tablet. So the lower the dose, the more sedating the drug is. The higher the dose, the bigger the antidepressant effect is, and the less sedating the drug is. So it's helpful in patients who have depression with insomnia. There's also something called Silanor. It's a newer formulation of an old tricyclic, doxepin. We generally don't like tricyclic in older patients because of the anticholinergic effects, the cognitive impairment, and the dizziness that they can produce. This formulation is only 3 to 6 milligrams, which is considered low dose. We still don't like using it in older patients, especially those with cognitive impairment. So that's something we use very infrequently and only if other things fail. And if you look at how effective it is, it's really not that effective. It maybe increased sleep time by about an hour over a 4-week period in someone suffering from insomnia. So again, I don't think the benefit of this outweighs the potential risk of anticholinergic activity. Next slide. So I'm going to skip this slide because this really doesn't address older adults. There are over-the-counter antihistamines that can be used in younger patients, but in older patients we don't use them. I want to spend a little time talking about the orexin receptor antagonists. They're the brand new class of medications used for insomnia, and they work a little differently than everything else. They basically block the orexin receptors, and what they do is they inhibit wakefulness. So they don't put you to sleep. They prevent you from being awake, which is a slightly different concept. The biggest issue with both of these drugs I have is that you have to stay in bed for at least 7 hours for a patient to be safe. And we know older patients get up frequently to go to the restroom during the night, so that often doesn't work for patients. It can contribute to cognitive impairment and behavioral disturbances. So again, in our patient population, not a great choice. And it can cause weird things like sleep paralysis in patients. It's contraindicated in patients with COPD, and a lot of our patients have that. So there are lots of problems with using both of these drugs. Half-lives aren't terribly long. Dave Vigo has a fairly long half-life, 17 to 19 hours. So that's another reason not to want to use it. But it's really looking at the package insert and looking at all the contraindications. It doesn't seem like a safe drug to use in older patients. Next slide. So this is a study that actually came out in JAMA in 2019, promoting this medication as an option for older adults. So the trick is in the details. When you look at the study design, the range age was 55 and over with a mean age of 63, which tells me that these are not very old patients. The patients we see in our clinic are 85 plus, most of them. And so this is a younger cohort of the older adults, so not necessarily a geriatric population. And then you look at the exclusion criteria in these trials, and they've excluded anybody that we see with insomnia, nocturia, patients with any kind of renal insufficiency, patients with other psychiatric diseases like depression and anxiety. Malignancy has been excluded. So these are this was a very tightly controlled study to get a better result. So the statistics showed that, it may be safer than Ambien, but again, look at the details. I still wouldn't use this drug. Next slide. So try non-pharmacologic therapy first. Sleep hygiene can be very effective if done right and the patient is motivated to do it. Professionals like, pharmacists, occupational therapists, nurses to do the sleep hygiene with your patients. Some supplements may be useful, but really reserve don't use a lot of Ambien or benzos because I think the benefit really doesn't justify the risk. How are we doing on time? Okay, so let's quickly go through.
Okay.
We're good? Okay. So let's quickly go through the pharmacologic management of depression. Next slide. So again, I'm a pharmacist, so the first place I look at is at the med list to see if any of the medications already being taken contribute to anxiety and depression. And my philosophy is if I can get rid of anything on the list that will shrink the med list and get rid of a potential diagnosis of anxiety and depression, I've done my job. So there's some medications on here that will produce anxiety symptoms like decongestants, beta agonists, even in inhaled form. Bupropion is a very activating antidepressant and can sometimes contribute to anxiety. Fluoxetine, same thing. Stimulants, steroids, and caffeine. That's a pretty self-explanatory list. In terms of depression, beta blockers will sometimes cause fatigue, exercise intolerance, and patients just kind of look tired and depressed looking. Clonidine is a centrally acting antihypertensive, which can slow you down as well, can also cause bradycardia and can make you look kind of depressed. Benzos, obviously. Finasteride, there's a nice study looking at older adults and depression, and it shows that when you use finasteride, it can contribute to symptoms of depression. I think by virtue of its mechanism of action, it blocks testosterone synthesis and kind of makes you feel more tired and old. Progesterone also has been shown to cause some depressive symptoms. Sedating antihistamines should not be used. Muscle relaxants, again, because they sedate you and make you feel tired. Steroids can cause both anxiety and depression. Narcotics can do it, obviously. And then indomethacin is one of those NSAIDs that's been linked to depression in older patients. And some calcium channel blockers, especially things like diltiazem and verapamil. Next slide. So there's lots of Beers criteria stuff on antidepressants. So they're all on the Beers criteria for increased fall risk, increased dizziness, increased risk for cognitive impairment when you're dealing with something with an anticholinergic profile like tricyclic antidepressants or paroxetine, which is the one SSRI with some anticholinergic activity. So this is where dosing comes in very important. Since they can all cause fall risk and dizziness, we really want to start them at the lowest possible dose and do a very slow titration to make sure they don't fall or get dizzy enough to fall. At higher doses, all of these drugs can also cause hyponatremia, so you want to keep an eye on the sodium as you're going up on the dose. And some medications have to be renally adjusted if your creatinine clearance is less than 30, like duloxetine is a good example. Bupropion has recently been removed from the Beers criteria because it was there for seizures risk. And really, it's a risk across the ages, not just in an older adult, so they removed it for that reason. But bupropion can definitely cause seizures, in this patient population. And again, it's very activating. It can also contribute to anxiety and insomnia. So be careful with it. Next slide. So are antidepressants as effective in younger patients and in older ones? Yeah, pretty much. There have been a couple of systematic reviews looking at older adults versus younger patients and antidepressants. Not every antidepressant will work in everybody, but overall the efficacy rates are similar. The biggest issue with older adults is side effects. So because of and withdrawal rates because of side effects. So you want to pick the right one for the patient, a low dose, titrate slowly, and really monitor for any new onset symptoms that they didn't have before, because they could be drug side effects. The other issue you have to keep in mind that most of these older patients will be on a giant med list for other problems, and so drug-drug interactions become an issue as well. Next slide. So the next couple of tables kind of go through each antidepressant and the benefits and risks of them. So on this one, we've got the SSRIs. Not every SSRI is the same. Things like citalopram and escitalopram actually have fewer drug-drug interactions than some of the other drugs. Citalopram has a pretty high risk of QT prolongation at higher doses. That's one of the reasons in the dosing column, the maximum here is 20. You don't want to go to the maximum of 40. And the dosing here, again, is key. You want to start with a low dose. In a younger patient, you can certainly start citalopram at 10 milligrams a day, but in an older one, you want to start with 5. Escitalopram is more potent. It's actually a more potent version of citalopram, so you would start with a lower dose still of 2.5 milligrams. Fluoxetine we generally avoid because it's a more activating antidepressant with a pretty long half-life. So you end up with a lot of anxiety, insomnia, and agitation in an older patient, even after you've stopped fluoxetine, because the half-life is so long that it just sits in your body for weeks. And again, if you want to use fluoxetine, the dosing has to be right. So you start with 5 and titrate up very slowly. Fluvoxamine is just not a commonly used SSRI. Mostly it's used for OCD, and it does have significant drug interactions. We generally avoid it. Paroxetine is the one SSRI with anticholinergic activity, so we don't want to use it in your cognitively impaired patient. And because it's got a short half-life, you're much more likely to have a withdrawal reaction if a patient is non-compliant. So that's another reason not to use Paxil routinely. And Zoloft, the most common side effect is diarrhea. It can be effective for anxiety or depression, but again, look for those GI side effects that are common, especially in the beginning of treatment. Next slide. So now you're looking at SNRIs. There's several, there are about 4 on the market now. The ones we most commonly used are things like venlafaxine and duloxetine. Duloxetine has an advantage of also being helpful in patients with pain. So all of these can be used for anxiety, depression, and duloxetine is specifically studied in chronic pain. So that might be an option for someone with lots of aches and pains. SNRIs in general will raise blood pressure, so you have to kind of keep an eye on that as you're titrating up the dose. But other than that, my favorite one of the SNRIs would be duloxetine because it can be used for different kinds of patients. Next slide. So you're really looking at side effect profile. How prominent will nausea, vomiting, and diarrhea be? Restlessness, nervousness, and sexual dysfunction are all common with SSRIs and SNRIs, and so you have to be careful to make sure patients are tolerating it well. Some things to consider is that SSRIs and SNRIs increase the risk of bleeding. So when you're using them in conjunction with anticoagulants or aspirin or Plavix, you have to look for You have to ask if a patient has a bruising or bleeding, which could be a drug-drug interaction. Again, hyponatremia at high doses, serotonin syndrome. You can run into this trouble if you're using like an antidepressant, for example, with a little tramadol, with a little trazodone for sleep. You've got multiple sources of serotonin coming at you. And so when you combine all that, you can put the patient at risk for it. And then when you're switching from one antidepressant to another, it's really helpful to taper, and so taper off one and cross taper on the other very gradually with slow dosing reductions and increases. Next slide. So some miscellaneous agents. So again, this is where mirtazapine comes in. Mirtazapine is great if you're having insomnia. It's great when you're having weight loss. It actually works. It's a more effective drug to cause weight gain than something like Provera, or Megace. So it's a good option for your frail elderly who are having trouble sleeping. Bupropion tends to be more activating. So I don't, it's not my first to do with older adults because it can cause agitation, insomnia, and weight loss in these patients. So you want to be careful with that. Sometimes it can be effective. And Trintellix at this point is brand name only. It's not covered by any other insurance. And so it really doesn't offer any huge benefit. Next slide. So just, select these drugs carefully. Look at the patient symptoms. Try to match drug side effects with patient symptoms. That way, these drugs will start working a little bit quicker than they normally would. Start with a low dose. Titrate more slowly than you would in a younger patient. Usually start with a half the dose that's recommended for a younger adult, and the titration should be twice as long. Avoid drugs with anticholinergic properties because obviously you don't want to cause cognitive impairment, dizziness, falls. And monotherapy is preferred. It's always better to use a single drug than a combination because then you're less likely to create a drug-drug interaction or an adverse outcome. And I think that's it. Thank you.
Thank you so much. Looks like we do have a question in the chat, Dr. Gurvich. Michelle Dossett said, given that many of the common antidepressants are listed here, what would you recommend using as an antidepressant in an elderly patient?
So I think it depends on the symptoms the patient is having. If they're losing weight, or having insomnia, then I would start with mirtazapine at 3.75 to 7.5, depending on how big the patient is. If it's just generic depression without insomnia necessarily, I really like either citalopram or Lexapro. I think they're generally well tolerated, and fairly effective. I like Lexapro better, but that's sort of, I can't really quantify that. Celexa is fine too. Fewer drug interactions with either one. The only thing you really have to worry about is QT prolongation with Celexa at higher doses, but you wouldn't go that high in an older adult anyway. If you're more comfortable, you can get an EKG to see if there's any QT prolongation at baseline, and if there isn't, you can go ahead and treat. So I always kind of tend to go that way. Does that answer your question?
Yes, thank you in the chat. Does anybody else have any questions for Dr. Gurvich? You're welcome to unmute yourself or type it in the chat. Okay, thank you, Dr. Gurvich, for that wonderful presentation. We'll definitely send the slides with our next email, so you have them for your reference. But we do have a case that's going to be presented by Dr. Sagel, so let me pull that up. Okay. Go ahead, Dr. Sagel.
Thank you, Nika. This is a little bit of a different case. It's very brief, and it's a very brief case with a very lengthy medication list that I was hoping that Dr. Gurvich could talk us through. This is actually a case that she and I saw and worked through together a number of years ago. And if we could scroll down just a little bit, it was a patient who came to the Senior Health Center at UCI. Who is is it blank?
Yeah, there was nothing there. Do you have
Oh my
one?
goodness,
Do you
yes, I
have one
do.
that you
Let
wanna
me share my screen.
Okay, let me stop sharing.
Give me 1 second here. Let's try that. Can you all see that case template?
Yes. Yes.
Okay. So this was a case of a 71-year-old man who came to the UCI Senior Health Center a number of years ago with the complaint of insomnia that had been going on for about 5 years. He had seen multiple providers in various specialties, including primary care, neurology, psychiatry, and some integrative health professionals, and came to us with the concern that he was unable to sleep. And he was also consuming large quantities of alcohol nightly to help him get to bed. I kid you not, his medication list included the following medications, which he was taking all at the same time. So he was on Ramelteon, anastrozole, temazepam, progesterone, amitriptyline, tryptophan, quetiapine, melatonin at very high doses, oral hydrocortisone, and DHEA. He was also on a number of supplements that were prescribed by an alternative medicine provider, for which we could never determine what was in these compounded products. He had no other chronic conditions, despite the hormones you see listed here. He was normal on MMSE and PHQ-2 and other assessment, and his main concern really was his insomnia. So I wonder, Dr. Gerbich, if you could talk us through some of these medications. Some of them seem very unusual for a male and for insomnia.
Okay, so this is a kind of a pharmacy nightmare. You have to kind of start from scratch with this guy. So I'll just go through the meds first and then kind of give you an approach of how to manage them. So Ramelteon is Rosarum, which is a melatonin agonist. So it really makes no sense for him to be on that and melatonin 30 milligrams. First of all, 30 milligrams is a huge dose. And if you're already on pharmaceutical grade melatonin-like drug, you really don't need the herbal supplement. I think part of the problem with herbal supplements is you never know what's in it. Sometimes it contains melatonin, sometimes it doesn't. So efficacy is kind of it's not consistent. So I would, if you want to get rid of one, if he's already on Ramelteon, I would probably get rid of regular melatonin and just cross that off the list. Temazepam and amitriptyline are huge no-nos in 71-year-olds. Amitriptyline has a really high anticholinergic profile, and it can cause a lot of confusion and dizziness in an older patient. Usually it's given at low doses, so if you have to discontinue it, like 25 milligrams is usually the dose for sleep, you could just stop it. You don't have to titrate it off. Temazepam, I would need to know how often he takes it, at what dose, and gradually discontinue it over a couple of weeks to a month, depending on how often he takes it. If they take a benzo every day, I will usually you can either tell them to cut the dose in half. With temazepam, they're capsules, so they're kind of hard to do, so you have to give them another prescription. But you could do it every other day, or you could give them, say, a 30-day supply and say, pick 5 days in a month when you don't take them, and kind of gradually wean them off. That way, decreasing the quantity you give them by 5 or 6 every month. So this might be a long process. Quetiapine, I guess, can be used for sleep because it's sedating, but it's really not a good idea because it can cause all kinds of other metabolic things like hypertension, hyperlipidemia, blood sugar goes up. So we really don't recommend using quetiapine just for sleep alone. If you're an agitated demented person and the behavior is dangerous, then you can use a low dose quetiapine at bedtime, but not for an average person for sleep. Usually the doses of quetiapine are low, 12.5 to 25, and again, you don't have to taper that off. You can just discontinue it. I don't know why they're on progesterone. I cannot imagine why a male would be on that. If my doctor gave my husband progesterone, I would tell him to go find somebody else, which I think is what we tried to tell this guy. I don't remember how successful we were. DHEA is a steroid-like substance, so I would be really careful within a 71-year-old man who could potentially have BPH and things like that. It can make that worse. Does that kind of cover a lot of it?
Yes, thank you, Dr. Gurvich. My recollection of this case, it was a number of years ago, was that we had actually, because of the hormone, because of the progesterone and the hydrocortisone, we actually had sent him to endocrinology to figure out if there was an undiagnosed or unknown hormonal issue that the patient was experiencing. And after a variety of testing, it was found that he did not require the use of these hormones for any reason. And he was advised to discontinue through endocrine. My recollection is that his quetiapine dose was 300 at night. It was a huge dose, which he did successfully come down significantly from. I don't think he was ever able to discontinue it, but he did come down significantly. And then he was lost to follow-up. He was actually driving to see us from probably about 2 hours away, and then was lost to follow-up.
So the other big issue here is that, look, he's consuming large quantities of alcohol nightly to aid with sleep. And so that in combination with a benzo, with a tricyclic antidepressant, with quetiapine is really dangerous and puts him at risk for all kinds of things, including falls and cognitive impairment and everything else.
Thank you so much, Dr. Gurvich. Thank you for allowing us to share this case.
Thank you. Does anybody have any questions about the case or recommendations even? Okay, any questions at all? Okay, well, let's go back to the slides and then I will close out. So just an FYI, I will be sending this PowerPoint to everybody in the follow-up email that comes later on today. Be sure that you do fill out the CME form if you do want CME credits. And we always love it if you fill out the session evaluation, because that will help us, determine topics for our next series. We do have our next and last session for this series coming up on February 18th on clinical pearls for improved chronic disease management for older adults, presented by Dr. Sarah Campbell, who's here today. So we look forward to seeing you then. And if there's no other questions, we'll go ahead and end just a few minutes early. Thank you so much to Dr. Gurvich and to Dr. Sagal for presenting today.